Thank you very much. We are here to talk about transport, and I'm going to move from the conceptual and policy-based presentation to a bit about why what Dr. Salfu was highlighting. Discovery, understanding, knowledge about the populations we treat, about the populations we all come from is so critical. And I will, as I do every day, recognize my wife for now. As I become demented, we'll see. But anyway, Michelle leads, as we've mentioned, the Institute for Genomic Health. And we really believe that we serve a population that is underserved, not in many ways, but also in our understanding of the basic biology. You know, we come from a construct where we believe in everyone being equal, but we also need to believe in the need for precision medicine, for understanding the individual, the population and community they come from, and that has a biologic background as well as a social, environmental background. Both are critical. We're stressing a bit on the genomics because a lot of the focus to date has been on the social, structural, environmental differences. Very little, in fact, has been done in genomics because our ability to study genomics has really been only recent. So, transport, focus on health disparities. You know, we use the term endowment, and everyone understands what endowment is, but I'm going to stick 1 second to say the goal here is not the $10 million over the next 5 years. The goal is the $500,000 a year forever that an endowment creates. Our goal, because we're allowed to, is to do phenomenally well with this first grant, and then we're allowed to submit once more for another $10 million, because our goal is to have $1 million of permanent funding. And that changes how our institution can really represent this focus on training and developing careers. And it is, as we've said before, a critical aspect of engaging with the community that we serve, the community that we belong to, the community that both of us immigrated into. So what I want to present relatively briefly is the importance of population health research. The key to translation into how we serve our patients. So it's not just a sterile process of learning at a basic level, but really how does it apply? And the importance of understanding our patients' genomic risk. But the other aspect of this is everyone worries about that focus on risk. Equally important is the focus on resilience. And what I need to highlight as we start looking just at a little bit of history, I'm a carrier of a particular birth defect that I learned about from 23andMe recently, and which means that I carry a mutation that happens 1 in 1,000 people. And if I had a child with someone else who carries that same mutation in 1 in 1,000 people, we would unfortunately have a child with that disorder. The odds of that happening are 1 in 1,000,000. Now, being a carrier has that problem. But the reason the gene exists as it does, the mutation, and keeps being passed on, is because in all likelihood, it actually has a particular strength, particular value to us as people. So being a carrier may make me vastly more resistant to a particular disorder or to a particular infection. And therefore, people like me are going to survive that risk preferentially to others who don't carry that. But it has a side effect that's an unfortunate thing in the very rare event of you having a child with someone that carries the exact same mutation. So as we understand genomics, It's not, as Michelle always says, fate or destiny. It is simply information, and in quite commonly, it is both a value as well as a potential risk. And the more we understand, the more that we can do. Another example is that as we understand an individual's particular genomic profile, we also understand how they will respond to particular treatments, the more appropriate treatments to that individual. And in today's treatment of cancer, it is almost become state-of-the-art, and it is state-of-the-art, that you not only have to understand the individual's genomic profile, but the tumor's genomic profile. And by doing that, we have gotten to the point where we can essentially cure people of cancers that were 100% fatal just years ago. And why? Because we can target only the tumor cell and not hurt any of the other vital tissue that we need. So, let's start with, I love starting talks, and this isn't starting, but with family pictures. But there is a point here. Familial is not always genomic. So that's obviously me and Michelle. These are our sons. Both Michelle and I trained at NIMH. So did Michael. Eric is a very good filmmaker, but has nothing to do with health research. However, these phenotype, the phenotype of having trained at NIMH, if it has any genetic component, it is minor, I suspect. I think the fact that he grew up with two researchers as parents who had trained at NIMH probably, in other words, a social environmental construct, is the dominant thing here. But we need to understand that that focuses us on familial will carry also strong information on the environment, on the way people are brought up, on the potential to develop in a particular way. I'm also a psychiatrist geneticist, and so what I wanted to highlight here is that two of the major serious mental illnesses that we have devoted our careers to are schizophrenia and bipolar disorder. There's population risks. The risks are significantly increased by 10 to 15 times if you are related in a first-degree way to, or even a second-degree way, to someone with that illness. But, for instance, twins tells us even more, because if you're a dizygotic, a fraternal twin, your shared risk with your twin is identical to any other sibling. If you're a monozygotic, identical twin, your shared risk zooms up to in the order of 50 to 80%, because your DNA is shared exactly. That's overly simplifying, but the bottom line is it tells us that there is a strong DNA-driven genetic component to risk for illness. It also tells us that you can carry 100% of the risk that may have contributed to an individual, the brother or sister that's sick, and then your identical twin still has a 30, 40, 50% chance of never developing illness. So it tells us environment is also critical. I want to just tell you that population has always been the focus of our work. So our work 20 some odd years ago, actually 28 some odd years ago, started on unique islands that are off the coast of Africa and Portugal, the Azores and Madeira Islands. And the goal there was to study populations that had become very much isolated. And that's a strategy that lets us study families and study the population as a whole. And in those studies, we actually collected and ascertained, and we have been going there probably 50 times over the last 28 years or more. We have grown to know these families. The patients, 70% of the patients with schizophrenia fall into 60 families in those islands. And we are just now funded through Dr. Ayman Fanouz, who is one of our collaborators in the chair of psychiatry, to begin to study, and this is both wonderful and horrible, the fourth generation. So the great-grandchildren who are now turning 20. We started with the great-grandparents, who were grandparents then, the parents, the children. There's illness in all these generations. We have known the generation we're studying now from birth. And they are, unfortunately, some of them becoming ill. A very interesting, very illuminating study that is going to answer things that are specific to that population and generalizable as well. And the other thing that's really important is DNA, holding that textbook, doesn't read the textbook, doesn't understand how we think of illness, and how we think of illness may have very little to do with what is actually going on from a DNA genomic point of view. So I'm going to give you a series of what's called Manhattan plots. I know we're in Brooklyn, and quite honestly, downtown Brooklyn now looks a lot like this too. But what they are is this is all studies of genomic profiling that look throughout the genome for where there may be risk mutations across the whole genome. And this is to show you the fact that I'm going to do a lot on schizophrenia, but we were participating in all of these studies. And this was the first study that showed that we actually identified 5 locations for mutations in the genome that were associated with schizophrenia. The most telling thing is to find 5 risk loci, and there are many more, involved 10,000 patients more or less and over 12,000 controls. So the most important piece of information here is that we in fact had to understand that very many people were needed. Let me describe that colorful chart on the side, graph. It's telling you about all the different populations that were brought together to be able to collect this population. One of the interesting things about it is that there are differences, but they're all differences within Euro-Caucasians. Everyone in these studies were from extraction, from ancestry from Europe. And the basis of most of this work in genomics 20 years ago, 30 years ago, was almost exclusively done with white participants. And there was a scientific justification, and that was that we needed massive numbers. And if we start bringing in multiple populations that were too potentially different, we would decrease the power, the ability to be able to actually find anything. And there was also an assumption that, and this is very critical, an assumption that a mutation in one population is not unlikely to be a mutation in another. I agree with that statement, but it's also not that it will always be, or that the mutations that are relevant in one population are actually particularly relevant in another. I'll quickly go through what happens when you advance. This plot involves 26,000 cases, more or less, against 28,000 controls. You're starting to see the downtown Brooklyn skyline, and even more the Manhattan skyline. Interestingly, that huge finding, let me tell you what that big skyscraper is. That's a finding that has statistical power showing at 10 to the minus 27. There are too many zeros to even get into. But this is showing us locations, and it's also very interesting because it's in the what's called mammalian histocompatibility locus. And that's the area that is very much always changing because it responds to infection. It's what develops our immune system's ability to recognize what's not us and to combat infection. We're still trying to figure out all the different things within that because there's so much within that one skyscraper that are directly involved, but it's becoming clearer. But you're also starting to see numerous findings. And at this point, it was 62. All right, this next one, 35,000 cases, 47,000 controls. And you're still seeing a very similar skyline, but there's more skyscrapers. There's more findings. We are up to 108. Now, again, the fascinating and unfortunate thing from our point of view, in terms of the populations that we serve, is that 98% of these results relate to to Euro-Caucasians. And so Michelle and I have taken it as a priority for the last 12, 13 years of focusing on the populations that are not represented in these findings. And it was a major driver for us to come to Brooklyn. We have been able to establish a relationship with the community, as we have in other areas, that I think really, really potentiates our ability to start to inform. And I'm not sure how we move forward here. Okay. So far, here in Brooklyn, this is an example of schizophrenia being studied with 3,000 African ancestry patients with 3,000 controls. And if you can sort of see, there's maybe a couple of skyscrapers becoming built, and there's actually a couple of spots where we actually are seeing strong statistical significance. For these type of studies, you need to find something that is 1 times 10 to the minus 8, meaning a 1 in 10 million chance of not being true. So we have a couple of new findings, but very few because the numbers are so small. If this had been a Euro-Caucasian sample, we would have had exactly the same thing. But we have what we know about all these other people who are of Euro-Caucasian extraction. So when we combine what we know from nearly 100,000 people with what we know from 6,000 people that we've already studied, we find an interesting issue, which is if you look at every one of those little green highlights, those are newly discovered mutations that were not found with 100,000 Caucasians. They're only found when you combine the background that we share with the knowledge that we gained from our population. And that is extremely important because as we add more, and that's the whole goal, we are going to find that there are areas that are predominantly relevant to a Latino population, to an African ancestry population, to any number of specialized populations. We're now dealing with a background of 150,000 Euro-Caucasians, but even a contribution of a focus on our community begins to tell us tremendously more about what's going on. And, okay, there, oops. It's supposed to be more slides. Can we restart? All right, well, so let me tell you what the other slide, 1 or 2, was going to show. The other thing that was also fascinating is that when you find areas that are shared between populations, when you look only in our white population, you find that the best signal we can get, even with 150,000 people, isn't narrow enough to tell us exactly what mutation in that area is relevant, but rather a rather broad inclusion of a number of elements in the genome. When they are shared between African ancestry, possibly Latino, and so on, the more differentiable populations you can bring together, you suddenly find that it may be this wide in Euro-Caucasians, it may be this wide, it tends to be narrower in African ancestry. But when you overlap them to what's likely causing problems, you find a much, much narrower overlap. So if you had 100 different things that may have fallen in the area of risk to study, the overlap may only have 10 or may only have 5. So it's tremendously illuminating into how to focus our important research work. So there's tremendous benefit to working on our populations. It is critical in terms of how we begin to apply, to translate what we're learning into how we treat our patients. It is extremely important and I'm going to give an example that Michelle often gives in her talks, to understand that we need to know our community and our patients in a very specific way. So again, I'm going to use schizophrenia as an example. There are a number of what's called typical antipsychotics, treatments that have been around for 30 years that work. But a lot of work was done to develop new generation antipsychotics that didn't have as many side effects. Well, it turns out that in the African ancestry population, the metabolism of the new agents works out that you have more side effects and less effectiveness than you do if you are Euro-Caucasian. So applying the more expensive, newer medications actually has less likelihood of helping. I'm generalizing. You need to caution, it works very well on many people, and I'm going to add that in a minute. But using the older medication also has better results. However, who is truly at the relevant place of African ancestry versus Euro-Caucasian? You're not going to know by how we look. Because what you are at a particular point in your genome has very little to do with what you look like as a phenotype, as an individual. And you may be, apparently, someone who looks like they came from Ireland, the family history is primarily Irish, but for that point, you have your ancestry as African ancestry. Or you might be completely associating yourself as being African ancestry, but as we know, there's a mixture in our population. At that point, you may need to be on one of the newer medications instead, because you've inherited a purely Irish ancestry there. So we need to get out of the sense that the only thing we need to do is to group in a social way people by how they define themselves. We need to understand the individual as much as we need to understand the communities. So there's relevance to the community because the vast majority of people that look one way or another might share certain more of the things, but we can't be that at that level. We have to go beyond that to the fact that we need to understand the individual as well as the community. Thank you very much.